So this is the outline. We'll start by looking at the counterfactual theory. We'll go into the Bradford Hill criteria, which are about 9. And then there are 2 examples of exam questions, though those are not, they're not detailed enough for the questions that I'd bring, but those are the questions that were in the slides that were in the notes from the Netherlands Pharmacovigilance Center. So like I said last week, I'm not really going to prepare notes for this. These notes are coming from the Netherlands Pharmacovigilance Center, LAREB, and they are prepared in conjunction with the WHO Collaborating Center for Pharmacovigilance in Education and Patient Reporting. So these notes are specifically for pharmacy students, nursing students, and medical doctors who are studying their first degrees. So yeah, basically that's why I haven't needed to prepare notes. So now, things that you'll be able to answer by the end of this lecture are, is it important to annotate the strength of the causal relationship between a drug and an adverse drug reaction? So for instance, if somebody experiences an adverse event and at some time point you gave them a drug, so how can you annotate the strength of a causal relationship between a drug and an adverse drug reaction? So we'll be looking at that today. How do you actually say that this adverse reaction was caused by a drug? And another question you'll be able to answer is, do you think it is possible to determine the strength of a causal relationship between a drug and an adverse drug reaction? So let's begin by looking at the counterfactual theory. This one is quite simple, and this is why there's actually the Bradford Hill criteria that is most commonly used. Obviously, the other methods, the other computerized methods that are really detailed in how an adverse event can actually be attributed to a drug, and that's called signal detection. But I think that it's too complicated for you, and I think that the Bradford Hill criteria and counterfactual theory should be sufficient for you, especially that this is your first degree and mostly you'll be doing practice and not specializing. So anyway, the counterfactual theory, when B, which is an adverse event, occurs after X, and then B does not occur without X, then X is considered to be the cause of B, isn't it? Think about it. B only occurs after X, but then B does not occur without X. In this way, you can say that X is considered to be the cause of B. So for instance, if someone entered his house and the house is B because the door was open and the door is X, that means that this person entered the house because of X, and so X is the cause of B. Now, in terms of drugs, because he uses this drug, which is X, he got an adverse drug reaction, B. So X causes B because the counterfactual, when X is not used, then B does not occur. So in this case, if X, or if the door is not open, it means that somebody cannot enter the house. So in this case, if somebody is not given a drug, then an adverse drug reaction won't occur. So this is basically the basis of the counterfactual theory. You have a drug X, okay? You have a drug X and an event B. When somebody is given, let me just get a pen. When somebody is given a drug X, then the event B occurs, as you can see here. If somebody is not given a drug X, event B will not occur. So the counterfactual theory is basically this concept here, and to describe it, this theory tries to answer the question, how do I know if something is a cause of a certain event? How do you know that a drug is what caused an adverse event. Remember, last week we looked at the definition of an adverse event. We said that with an adverse event, you could have given the drug to this individual, but you're not sure whether the drug is what caused an adverse reaction. Because you notice how I haven't said adverse drug reaction, it's adverse reaction. And remember, our definition of adverse reaction is what you see symptomatically or organically, or how somebody presents after they've experienced an event, okay, or a physiological or biochemical event. And so in terms of when you're given a drug, how do you know that the drug is what has caused what you're seeing? Okay, so it's a theoretical approach, but it doesn't provide a practical solution for the assessment of the causal relationship. So how do you solve this problem? Because in the counterfactual theory, all you're saying is you've given a drug X and an event B has occurred. And without X, the event B does not occur. Okay, so now how it's very limited, as you can see, and it's very superficial and shallow. So how do you solve this problem? You can, in terms of trying to prove that a drug actually caused a reaction, you can use control groups, and you can also assess individual cases. I don't know if you've done the types of studies like in your research methods. I don't know if you've done kind of observational studies and experimental studies, and then under observation, I don't know if you looked at cohort and case control and cross-sectional studies. Have you done this in research methods?
Yes, we did.
Okay, so that should be easy for you. You know about control groups, whether it's experimental studies or whether it's observational studies. You know about control groups, isn't it? Do you know what control groups are? So that if you don't, I can explain just a little bit here.
Madam, for the sake of saving lives, you can go ahead and explain.
Okay. All right. So you know that, okay, I think I'll explain this in terms of clinical trials, because that's basically something that I handled. Okay, so remember that in phase 2, phase 3 clinical trials, you had control groups, right? So control groups are basically, well, they are controls. Okay, so you, in clinical trials, for instance, you'd be giving a drug, right? You're experimenting, you're testing a drug for efficacy or for safety. Well, let me just say for efficacy, testing a drug for efficacy in clinical trials to see whether this drug can actually treat a disease. Okay, so if it's an anti-malarial, these people maybe have malaria, and you're giving them a drug to see if it's safe. So because we're looking now at adverse drug reactions, so want to see, does this drug actually cause a reaction? Now, in a control group, okay, I won't look at in terms of a disease, but in a control group, you can either have a group that does not have the disease and is not given the drug, or B, you can have a group that has the disease but is not given a drug. So those are examples of control groups. Okay, they can either be a group that does not have a disease and is not given a drug, or B, they can have a disease but they are not given a drug. And obviously, when it comes to clinical trials, you wouldn't really it would be unethical for you to know, or for you to not give a drug when there's a drug that is efficacious, of course. So it varies from disease to disease in terms of control groups. But in case of adverse drug reactions, now I'm zooming back into this topic. In terms of adverse drug reactions, determining whether a drug would actually cause, in trying to assess whether this drug caused an adverse drug reaction. A control group is where you obviously do not give a drug to these people. You can be giving, they could either, again, be healthy and not, they could be healthy and not given a drug. They could be diseased and not given that exact type of drug. They could be given like a different drug, maybe even in a drug that's in the same class. Okay, so those are examples of control groups. Anyway, I will explain this as we start looking at the Bradford Hill criteria, especially when we start looking at the strength of association. At the same time, you can also assess individual cases to see whether a drug actually causes a reaction. So the epidemiological approach in determining safety or an adverse drug reactions, you can have patients that use a drug X, and then there can be occurrence of B given the use of X. This is an epidemiological approach. That's why I asked you if you've done this concept in research methods, epidemiology, and biostatistics. So, and then you can have patients who are not using X. Then you want to see, does the adverse reaction B or an adverse event B occurs even if somebody is not using X? So let's say, let me give an example of lung cancer, right? You can have a group A who are using, who take cigarettes. A group A who are taking cigarettes, and cigarettes in this case would be X. You follow them up over time and see the chances of them developing lung cancer, which is occurrence B. And then you can have people or group that are not cigarette smokers, and then you follow them up over time to see whether they develop lung cancer, even if they do not use cigarettes. Okay, so when both groups are exchangeable and B differs between both groups, we start that B is a causal relationship with X. And so that means that if B does not occur as much in people who do not, it doesn't occur at all, or it doesn't occur as much in people who do not smoke, but it occurs maybe even 100 times more in people who use X, you can say that X or cigarette smoking is a cause of lung cancer, or people who smoke cigarettes are more likely to develop lung cancer. Okay, so in medical practice, you might not really have control groups. Of course, if it's clinical practice, for instance, and you've given a drug, let's say you've given antipsychotics to somebody, and then they develop this adverse drug reaction, you might not have a control group in order to assess the strength or to determine causality, as the drug caused an adverse drug reaction, or even if you receive, working at the WHO Uppsala Monitoring Center, and you're receiving adverse drug reaction reports from the entire WHO region. So you're receiving adverse drug reaction from every country in Africa that belongs to the WHO. Well, that's a member of the WHO Uppsala Monitoring Center. They submit the adverse drug reaction reports to the Uppsala Monitoring Center. So let me give an example. As Zambia, as I said last week, Zambia, we do submit adverse drug reaction reports. You can submit by the Med Safety app. You can submit you can submit online, and you can submit a hard copy report. So whatever the case is, those reports are going to go. We don't have a database here, so it can't really do assessments, but those reports are all going to go to the WHO Uppsala Monitoring Center. So that's the same other countries that are members of the WHO in terms of pharmacovigilance. So all those reports will be sent to the WHO Uppsala Monitoring Center, and they can use the Bradford Hill criteria initially to try to assess causality, even though there are computerized methods now that are used in terms of signal detection to actually see whether a drug actually caused an adverse drug reaction. So now those are epidemiological methods where you have groups of people and control groups. But what if you don't? Okay, so this is where you have now the Bradford Hill criteria. So Mr. Hill, was it Dr. Hill, he wanted to give us an idea of how can you determine that an event is it could be any of those things, or is it caused by the non-intervention? So there are all these issues, and so the Bradford Hill criteria are 9, and in this lecture I'll just be going through these 9. I hope that you are taking notes. I don't think that um, the notes are quite detailed, but whatever the case is, at the end of these slides, there are some papers that you can look at that do describe the Bradford Hill criteria. And so we'll start by looking at the strengths of evidence. Okay, so a question to you. Do you guys know about relative risks and odds ratios? Have you done relative risk and odd ratio calculations in research methods? Okay, nobody is answering me. Have you done relative risk and odds ratio calculations in research methods, epidemiology, and biostats?
We did, but you can still emphasize.
Okay. Well, okay. So you know when epidemiological studies, anyway, you know that there are cohorts and then there are case controls, and you know with cohorts, you have the exposure first. You're following them up through time prospectively, and then you have an outcome at the end. Okay, so that's with the cohort study. So with that kind of study, when you're trying to determine causality, you use relative risks. But when it comes to case controls, you already have a disease. Okay, we already have an outcome, and then you're going to go back through time, which is retrospectively. You're going to go back in time to try to find out what exposures could have caused that outcome or disease that you're seeing. And so with the strength of evidence, what you have is exposure, let's say to a drug. Okay, you have people being exposed to a drug, and then you have an outcome. So strength of evidence, you know about the relative risk calculations. I'm pretty sure you've done that. So basically, I won't show you the calculation itself, but I'm just going to show you, what you use. Sorry, that's just a terrible illustration. But you can have maybe your disease, no disease, and then maybe you can have your exposure and no exposure. You remember that table that you would, sorry, you remember that table that you would draw in order to determine the relative risks. So if you did discuss relative risk, you know that if somebody has a relative risk of 1, if somebody has a relative risk of 1, it means that there's no causality there. It means that that risk or that exposure did not lead to an outcome. So in the case of progestogens and the occurrence of venous thrombosis, okay, if somebody has a relative risk of 1, if people who are exposed to a drug and have a certain outcome, and people who are not exposed to a drug and have a certain outcome, if the relative risk is 1, it means that the drug did not cause that disease. And in terms of progestogens, if exposure to progestogen and the occurrence of venous thrombosis and the relative risk is 1, it means that progestogens did not cause the venous thrombosis. So there's no association or there's no causality. But if somebody is exposed to first generation progestogens and the relative risk calculation gives you a 3.2, any relative risk above 1, you know that there could be an association there. There's an association. So 3.2 can tell you that Exposure to progestogens is most likely to result in the occurrence of a venous thrombosis. And with second generation, if your relative risk calculation gives you 2.8, you'd still say that there's an association there. And if there's exposure to third generation progestogens, and then your relative risk calculation gives you 3.8, you'd say that there's also an association between exposure to progestogens and the occurrence of venous thrombosis. Now, you can see that there's a difference here. All of these obviously are greater than 1, but there's a level to it. Obviously, 2.8 is lower than 3.2, and 3.2 is lower than 3.8. Okay, so you can see that third generation progestogens are most likely to result in the occurrence of venous thrombosis than our first generation, than our second generation, and than is non-use of progestogens entirely. So in this case, you can say that a relative risk calculation can help you determine causality. Okay, if in this case, as you can see, the third generation progestrogens result in a relative risk of 3.8, you can say that they are more likely to result in a venous thrombosis than is the non-use of progestrogens, or than is the use of second generation progestrogens. So this is to say that in order for somebody to determine causality, especially like this is most common cohort studies. Okay, so let's say that the Uppsala Monitoring Center has received reports that people who are given progestogens are developing venous thrombosis. So people, healthcare professionals, pharmacists are sending reports to Zama. Zama is forwarding to Uppsala Monitoring Center, and Uppsala Monitoring Center have received reports from several countries or several healthcare professionals and patients to say that venous thrombosis is resulting because of administration of progestrogens. So what happens is that now it's up to the WHO maybe to conduct, or even scientists, they'll conduct, or a pharmaceutical company, they can conduct a cohort study, okay, in which there will be people who will be in group A, will be given third generation progestrogens. Group B will be given second generation progestrogens. Group C will be given first generation progestrogens, and group D will not be given any progestrogens. And so they'll follow them up through time, let's say maybe a course over a year or a couple of years, just to see. And obviously they'll be monitoring their platelet counts, the coagulation factors, and so forth, to see what are the chances, or even the actual outcome, to see will these people actually develop a venous thrombosis. So when they do, they'll obviously place them in those groups, and they'll say exposure and the occurrence of the disease. How many people have been exposed to the drug, the progestogen, and how many people have developed the disease. So if you have 1,000 people participating in a study, you have 1,000 people participating in a study. Out of those 1,000, you have 1,000 people exposed to a drug. How many people have developed venous thrombosis? Let's say 700 have developed venous thrombosis. How many people have not developed? Another 300. Okay, so how many people have not been exposed to a disease? Another 1,000. How many people have developed the venous thrombosis? Let's say 200 have developed venous thrombosis. How many people haven't? 800. So you do your relative risk calculation, and if your relative risk calculation for the third generation gives you 3.8, second generation 2.8, first generation gives you 3.2, truly you can see that there's an association here between exposure of a drug to the development of venous thrombosis. Of course, here you can stratify by the generation. Pretty sure you know about stratification of the exposure groups with a disease outcome in order to develop to determine causality or to do the relative risk assessment. So anyway, this is how it's done. So even you can say the Uppsala Monitoring Center can use this method, and even pharmaceutical companies or university. So whichever group is trying to determine causality can do this type of cohort study in order to determine the strength of association. And that strength of association is determined using the relative risk. And obviously there will be confidence interval. And whenever you're doing these cohort studies to determine what is causality, all the time, in order for you to be sure that there's an association, your confidence interval should never go to 1, like it is here. Like with 1, then you have some doubt, or even 0.8, because you can say that there's some protection, or even 0.6. You wouldn't really be certain here, and so you'd have to maybe expand the number of people you conduct your clinical trials in. And your clinical trial obviously being a cohort observational study in order to determine the strength of association. So these are the studies I don't know if you've read about them or heard about them, where you have a group of people who have exposed to a drug and a group of people who aren't. So even with how lung cancer was attributed to cigarette smoking, you could say that there were a group of people who were exposed, or you would collect data from a group of people who smoke cigarettes, and they would also collect data from people who don't smoke cigarettes. They followed them up through time, and they saw how long, or they saw how many people who exposed smoke developed lung cancer and how many people didn't. So it's the same case even with drugs. How many people exposed to a drug that developed a disease and those who didn't, and how many people were not exposed to a drug and didn't develop a certain disease. So this is it with the strength of association. Is there any question? I move on to the next criteria for Bradford Hill criteria. Anyone with a question? Okay, I'll assume that's clear, and I'll move on to the next one, which is order in time. This is generally called temporality. I prefer to call it temporality, so I'll probably use that term when it's to your test and so forth. So temporality. Okay, so you have exposure, and then you have an outcome or disease. At which point in time did you give a drug? Or are we saying, okay, this is how I'll phrase it. Did the drug actually cause an outcome or a disease that you are seeing? Did an exposure to a drug actually cause a disease? So this is temporality. Okay, so they'll ask you, sometimes like they can call you, I don't know if they do that here in Zambia, if the people in the pharmacovigilance unit call when it comes to an adverse drug reaction report to actually try to determine temporality. But generally, I think this is just common sense. You would expect for you to attribute an adverse reaction to a drug or an adverse event to a drug, you must give the drug before that reaction occurs, isn't it? You'd expect that you would give a drug before event. Now, sometimes it's complicated. It's not as simple as that. If it's simple, if let's say like if you get a bee sting, the bee stings you, and at that very same spot where the bee stings you, there's inflammation. It's easy to say that the bee sting is the one that caused the inflammation, isn't it? And so even with a drug, when you see that, okay, you've given somebody penicillin, then they develop Stevens-Johnson syndrome, or they develop a reaction, immediately you can say that, yeah, the drug probably caused this reaction, and you write a report so to say, I gave this drug, and then a few minutes later, somebody developed a reaction. Or even if somebody is applying a skin cream, let's say, give them the skin cream, they develop a reaction, or even a drug, they develop a reaction. You'd say, yeah, it's likely they did not take any other medication. They do not have any other condition. This does not look like it's a condition that developed on its own. So it's probably the drug that caused the reaction. Now, it's difficult when the condition, because sometimes conditions develop very slowly. So you can give a drug when somebody has already started developing they've already started developing a disease, or the disease has already started progressing, and you give the drug right squat in the middle of that disease progression. So how do you determine exactly that? So again, you'd have to use not just temporality itself, but also other criteria for the Bradford Hill criteria to determine that. So an example of how complicated this is what I told you last week, where women who used to take diethylstilbestrol for like morning sickness. So imagine a pregnant woman is taking diethylstilbestrol for sickness. She has a baby girl. That baby girl grows up. Okay, this is now obviously maybe decades later, and that girl develops vaginal cancer or an adenosarcoma. Just imagine how difficult that must have been to attribute a disease to a drug that was given in the previous generation. Okay, well, obviously while you were in utero. So this is temporality. In order for you to determine causality, there always has to be temporality. Have you given a disease before an outcome? And obviously sometimes there are complications of you giving a drug right in the middle of disease progression. And even then, there are other criteria that you can use to determine causality. So anyway, I think that one is simple and straightforward. You always have to give a drug before you see an outcome of a disease. You cannot say that after somebody has already developed lung cancer, then they started smoking cigarettes, that the cigarettes are the ones that cause the lung cancer, because there's no temporality. Okay, it doesn't make sense. So yeah, this is it with temporality. The exposure to a drug always has to come before the disease outcome. So what methods, what kind of study can somebody perform here in order to determine causality? Would it be a cohort study? Would it be a cross-sectional study, or would it be a case control? Can you tell me what kind of study somebody would have to perform? What kind of study somebody would have to perform here that would be ideal in order to determine causality? Anyone who thinks that they can take this question?
Yes, madam. Hello.
Yeah, go on, Commander, I can hear you. Derek, go on, I can hear you.
I'm thinking cohort because since there is some disease outcome that may take time to emerge, so you may need to use cohort which perspective and the perspective. You can go back and to us find out what kind of an app did the patient take for the images of that disease outcome. Or again, you can follow up. Yeah, I think the best way is of both the retro and prospective. I'm thinking.
Okay, so are you saying it should be a retrospective and prospective cohort study?
Hello.
Yes, I can hear you. Okay, so this session is about to cut out. Let's continue this discussion in the next meeting. So just join back in quickly and we continue with this discussion. And then, yeah.